where 100 top doctors from around the world come together and share their knowledge with their colleagues. Today, our special guest is from India. Dr. Inderpreet Singh is a practicing dentist in Lucknow, India, after graduating from the King George Medical University. Dr. Singh started his practice in 2010, which focuses on implant dentistry. He has an active interest in implantology and hence he started a Facebook group following his passion of bringing all the implantologists from all over the world under the aegis of Implantology. In December 2017, Dr. Singh has attended various conferences of implantology and has keen interest in bone regeneration. Dr. Singh has also attended international digital hands-on course in recently in Bangkok by Dentium. Welcome, Dr. Singh.
Thank you, sir. Thank you so much. It's been a pleasure to be invited by Dr. Arun Garg, and I'm so thankful to him and his team. That is, and also Dr. Kianor Shaw. Thank you so much. So the topic for today is optimizing the alveolar ridge. Just a minute. Right. Now, what is the need for optimization? It is to prevent further resorption of the alveolar ridge, to maintain the existing bone volume, for making the ridge conducive to various prosthodontic procedures like dentures, implant supported prosthesis, and in this, the role of soft tissue, the thick keratinized over the alveolar bone or surrounding the implant that cannot be underestimated. Ridge preservation for single tooth extraction. After single tooth extraction, what do we do? There are two techniques. One is socket preservation and the other is socket shield. Socket preservation, after the tooth is extracted, graft material is placed in the socket covered by a membrane. This helps to preserve the bone volume after extraction and is done when an implant isn't planned immediately. Now, what is socket shield? The buccal part of the root is left along after the sectioning of the palatal part along with the apex. This helps in preserving the buccal contour. No grafting is required, and an implant can be usually planned immediately or a delayed one. We'll come to socket shield later. Socket preservation. Now, what happens when a tooth is removed? We preserve the bone by not stopping the remodeling. We cannot stop the remodeling, but by decreasing the dimensional and volumetric changes post extraction. In our colleges, we were taught to compress the extraction sockets, but that has altogether changed. We never compress an extraction socket after extraction. We follow atraumatic tooth extraction. It is estimated that approximately 40 to 60% of original height and width may be lost in the first 2 years following extraction. This is a schematic diagram showing how the loss of vertical ridge height happens. Now, graft materials being placed inside the socket. It could be a bovine bone, it could be mineralized versus demineralized allograft, autogenous bone, the gold standard, mineral tricalcium phosphate, or a combination of the above. Scientific evidence says no clear guidelines in regard to the biomaterials for the surgical procedure have been there. Now coming to socket shield or root membrane technique. Despite the use of biomaterials, there is definitely some loss of buccal bone contour. Especially in the aesthetic regions, this results in the loss of papillary height and gum recession. Husserl first termed the technique socket shield and demonstrated the concept histologically in a canine study. In socket shield, we decoronate the tooth, and the root is then sectioned mesio-distally. With the buccal portion, you keep it inside, and the palatal one is extracted. Now, why the need for a socket shield? We know that the buccal bone is made up of buccal bone and the palatal bone. It is thinnest in the coronal portion. According to the studies by Mauricio and Roger Melendez, the dimension of bundle bone was 0.2 to 0.3 mm on the lingual plate, while it was chosen on the buccal surface. So the more it is clear that the bundle bone belongs to the trivial result following a tooth loss. And after tooth loss, what happens? They found the buccal bone was lying 1.9 mm apical to the lingual crest following extraction. This is huge. So what we do in buccal shield, in the socket shield, the buccal portion of the shield is then modified into a concave shape depending upon the requirement of the tooth and the adjacent tooth. An immediate implant is usually placed in the palatal wall of the hair. The space between the shield and the implant is left as such to heal without any graft material. A healing abutment is placed over the implant and then allowed to heal for 2 months. The shield, you must remember, should not be mobile, not periodontally involved, and must be healthy and strong. This is the diagrams of socket shield. Now coming to osteodensification. It's a newly developed technique that helps in creating an autograft layer of condensed bone at the periphery of the implant bed. Utilizes a series of specially designed drills for preparation of the osteotomy. These drills are rotated in clockwise or counterclockwise direction depending upon the bone quality and the manufacturer instructions. What helps what these drills help is to increase the BIC, the bone implant contact, and thus we achieve a good primary stability, which is good to have in a immediate implant or something like that. These drills also help in ridge expansion. The difference between standard drills and these tensor drills. The standard drills tend to excavate bone when run in clockwise direction. These drills, the tensor drills, condense bone when run in counterclockwise direction, combining the benefits of both osteotomes, which are used to compress the bone, and standard drills also. The chatter is also not present, which you if you run a normal drill in a clockwise or counterclockwise direction, these drills don't have a chatter. Osteodensification does not remove bone in counterclockwise direction as told earlier, and hence preserves bone in narrow ridges where the bone width is very crucial to not allow to be less. This is the company that makes the osteodensification drills, the Versa. These are the drills with burr laser lines. Now coming to ridge split. What is ridge split? Ridge split is a technique utilized for narrow ridges where a conventional implant placement would otherwise not be possible. Till Tatum is given the credit for working with ridge expansion protocols in 1970. The protocol then included taper channel formers, D-shaped osteotomes, and custom implants. Now, since then, many advancements have further made this technique easier. Scipioni et al. Reported a 98% 5-year survival rate of implants when utilizing ridge split along with simultaneous implant placement. Summers et al. Further reported a 96% survival rate in 143 maxillary implant osteotomy cases. Sethi and Kos performed bridge expansion in 150 patients, and they also achieved a 97% survival rate at 5 years. Lastman and Levenstein demonstrated a number of key elements to ridge expansion technique with simultaneous interpositional bone grafting. We can also use interpositional grafting, or if the jumping distance is less than 2 mm, we can just leave it as such. The indications for ridge split are a narrow alveolar ridge, which has to be minimum 2 plus mm and has to have a marrow component. Primarily, it is indicated for maxillary sides and go for greater than one tooth. If in the mandible, only in distal extension cases we do a ridge split, and that too, the bone has to have a narrow component. Adequate alveolar bone height, it has to be 10 mm minimum. Sinus slip also we can do a ridge split. The contraindications: inadequate alveolar bone height, the concavities or undercuts, fused cortices, as I said, absence of marrow is not an indication for ridge split. Less than 2 mm bone width, again contraindicated. Single tooth sides are also contraindicated because there you can easily do osteodensification. This is a ridge split kit by Dentium that I normally use. Key points. The implant osteotome, it has to be remembered, the implant osteotome follows the dense palatal bone when you do a ridge split. Hence, ridge split and simultaneous implant placement result in a facial implant angulation. You must also take into account interocclusal space and parafunctional habits if present. It must be taken into account because a lot of force will be generated. The failure to perform the procedure correctly can result in catastrophic bone loss, buccal plate fracture. Osteodensification you can also use with ridge split. You can gain even more width, especially in the mandibular distal extension cases. And a piezo surgery unit can also be used to perform a precise ridge split, though it is slow, but it is very precise. Uh, we start with a blade for a ridge split and then continue with the chisel and everything. If you're using a piezo, you can use a piezo also. You can use a piezo also. Maxillary sinus augmentation. The maxillary posterior area presents unique challenges for implant rehabilitation. After tooth extraction, resorption occurs fast and sometimes leaves little bone height for implant placement. The occlusal forces are the maximum in the posterior region, and bone in this region is again the softest. Now, sinus grafting was first described by Boyle and James and Teta. The anatomy of the sinus is unique and must be understood before anybody jumps onto maxillary sinus lift. The maxillary sinus has a horizontal pyramidal shape consisting of a base, an apex, and four sides. Now imagine it three-dimensionally. The base medial wall forms the vertical lateral wall of the nasal cavity. The apex is at the junction of the maxillary and zygomatic bones. The remaining three sides of the pyramid form the superior, anterior, and posterior walls of the sinus. The superior wall, which is also the floor of the orbit, makes up the roof of the sinus. The anterior wall makes up the facial wall of the maxillary bone. The posterior and lateral walls merge to form the posterolateral wall of the sinus, which separates the sinus from the infratemporal fossa and forms the maxillary tuberosity and the pterygoid fossa. The medial wall demarcates the maxillary sinus from the nasal fossa and supports the middle and inferior concave. In the anterosuperior area of the medial wall is present an ostium, a 7 to 10 mm long passage that is the communication between the maxillary sinus and the nasal cavity. The ostium, the infundibulum, and the middle meatus are often collectively called as the osteomeatal complex, which is very important. The communication or the ostium has to be kept patent in all cases to ensure that the health of the maxillary and paranasal sinuses is good. The osteomeatal complex must be visualized radiographically before attempting a sinus lift, and hence a CBCT is a must in these days before you attempt a sinus lift or any other procedure, GBR procedure, anything you do. You must have a CBCT before it. The epithelial lining is a single layer of pseudostratified columnar ciliated epithelium. The blood supply consists of posterior superior alveolar artery and intraorbital artery. These arteries are very important. Why? These usually form an anastomosis, which could be both intraosseous or extraosseous. Soler et al. Told us it is assumed that the periphery of the graft receives blood supply from the intraosseous, and the center of the graft receives blood supply from the collateral branches of the endoosseous anastomosis. So the preservation of this blood supply during the sinus lift, lateral or indirect one, is paramount. We must always visualize this anastomosis on a CBCT. We can always see this artery, intraosseous artery, on a CBCT if we look at carefully. Hence, again, the importance of CBCT cannot be undermined. This is a schematic diagram of sinus. Lateral sinus augmentation. So, although any graft or even no graft material might well be sufficient for a sinus lift procedure, especially in the lateral lift or the direct sinus lift, we usually add a mixture of allograft and xenograft, and it works quite well and it heals well. A bony window is made with a round burr or a piezo, preferably. After the removal of the window, an off-angled sinus curette is used to undermine the sinus layer from the bone to approximately 3 mm. Now, should any membrane perforation occur, which might occur, you must change the direction of the curette, place a membrane covering the perforation, and then graft. Usually, the procedure heals well, and the sinus lift is very well achieved. It's a very good procedure, very predictable procedure. Crestal sinus lift, which has been practiced, which every surgeon likes to do because of less mobility involved. The osteotome-mediated crestal sinus lift was first proposed by Tatum in 1917. Summers coined the term osteotome technique, whereby a set of osteotomes with variable diameters were used to produce a green stick fracture of a sinus floor, which is then lifted. It is very good for cases with residual bone height of 5 to 6 mm. We use two types of osteotomes. One are convex and one are concave. Convex osteotomes, they help for bone compression, while the concave osteotomes have a cutting edge at the periphery for bone cutting. Concave osteotome is introduced 2 mm beneath the sinus floor. Then a large sized osteotome is used in pushing up motion of the sinus floor via the residual bone. Finally, an implant is placed with the bone apical to the implant. It lifts the sinus floor. First, we introduce a concave, then we push with a bigger size convex osteotome. It helps in condensing the bone and the graft, and then the implant also pushes the graft, and the sinus lift is achieved. We can also place multiple implants with this, but the anatomy has to be understood. The left we can see. Osteodensification can also be used for sinus lift. What do we do here? We underprepare the osteotomy always because the bone is D3 to D4. Again, osteodensification burrs are used in counterclockwise direction to focus irrigation at 800 to 1200 rpm. Osteodensification burrs have a large negative rake angle, hence the bone is laterally compressed with least of chatter, no chatter at all, causing compaction autografting or osteodensification, and hence it increases the primary stability of the implant. We could easily say that we convert a D3 to D4 bone to a say D3 we convert into a D2 and D4 we convert into D3. So that helps in increasing the primary stability. There we are. So there's some criteria that general criteria that can be followed for making a judgment over a lateral or a delayed implant like this. The residual bone height or RBH is between 0 to 4 mm, you could go for a lateral sinus augmentation. When it is between 0 to 2 mm, you should always delay the implant placement. The residual bone height between 3 to 4 mm with simultaneous osteodensification you can do, and implant placement can be done. And when it is between 4 to 8, the residual bone height, you can always go for a crestal approach with simultaneous implant placement. However, if you go check for a perforation with the Valsalva maneuver, if we go for a perforation, then you have to shift to the lateral approach. You should always be prepared for a lateral approach and then use a membrane and then complete the lift. The complications that can occur while doing sinus work. The incision line could open, resulting in graft extravasation or infection. Nasal bleeding, though it's uncommon, can occur. The infection of the grafted sinus which will occur usually 7 to 10 days after surgery, or collective sinusitis of all the sinuses will take place. So, the risk factors are: if the patient has a history of chronic sinusitis, you don't go for a CDCP, don't put the patient on antibiotic coverage. The anatomy you fail to recognize, the internal anatomy of the sinus, the bone peaks you fail to recognize, that could lead to a tear of the membrane. The dentoalveolar pathology that could occur, sinus membrane pathology could be present, the residual ridge volume could be less. Smokers, systemic medical conditions, surgical technique did not follow asepsis properly, osteometal obstruction, membrane perforation, contaminated bone graft you used, graft extravasation, and the operator experience is the foremost in such a procedure. Now, ridge preservation for multiple sites. Guided bone regeneration involving the use of autogenous bone and xenograft or mineral phosphate along with a membrane to regain lost volume for a single or even multiple implant sites, followed by simultaneous or delayed implant placement. The earlier membranes was the extended PTFE membranes, or you could use a resorbable one like we do these days, which is the collagen or the polylactic or polyglycolic acid ones. The disadvantage because of which the ePTFE membranes were discontinued were that they usually had membrane exposure. They were difficult to handle because of their hydrophobic nature. The addition of autogenous bone chips are essential addition to the xenograft as they provide signals for osteogenesis. Autogenous bone chips are the gold standard. If you don't add them, it might help, but you have to add. We tried SAC complex for this thing. What is the biological basis of GBR? Now, bone reveals a unique potential for regeneration as it does in fracture repair. This potential we utilize for the basis of utilizing the bone augmentation to the best prosthetic use. Bone is made up of four types of cells: the osteoblasts, bone lining cells, osteoclasts, and osteocytes. Sufficient blood supply is always the needed for bone regeneration. Osteoblasts originate from mesenchymal stem cells in the bone marrow. Now, you must always understand that bone is never static. It might appear to be static, but it is never static. It is always in a state of flux. It is always remodeling, never static. The modeling is also influenced by cytokines, various hormones such as parathormone, calcitonin, calcitriol. So the remodeling is different in different individuals. Osteoclasts originate from hematopoietic stem cells. They cause, as we all know, bone resorption. The repair of bone defects closely resembles appositional growth. Now, what is osteoinduction? By the growth factors releases from autologous bone particles. Osteoconduction is by autografts, allografts, xenografts, or alloclasts. Osteoconduction facilitates the filling of larger bone defects by providing a scaffold on which bone can be deposited. The substitution rate of all the graft materials are variable. Bone grafts and substitutes. Now, the purpose of bone graft in GBR, it is to support the membrane to avoid membrane collapse. It will act as a scaffold for bone ingrowth from the recipient side. It stimulates bone ingrowth from the recipient side, supplies a mechanical shield against pressure from the overlying soft tissue, and also protects the augmented volume from resorption. So the autografts, allografts, xenografts, alloplastic materials could all include fresh frozen bone, which is lesser use demineralized or freeze dried bone allograft. And then we use calcium phosphates, bioactive glasses, beta TCP like. Often we will use a combination of two or more graft materials, which will help us achieve an acceptable outcome. Particle graft size is 100 to 500, and a low substitution rate for a non-resorbable graft is always preferable when the implant placement is delayed or as in aesthetic cases. Now coming to autografts, they can be harvested from the chin. I think Dr. Arun made a good, very good, a very good presentation on this autologous bone grafts. Must see that presentation. So they can be harvested from chin, mandibular body ramus, nasal spine, maxillary tuberosity, zygomatic body, or even the tori. Autogenous block graph. I just uh, skim through these things because that presentation is the gold standard, I think, by Dr. Arun. The block graphs are the only graphs that offer mechanical stability against pressure from the overlying tissues. They are immobilized with fixation screws. The benefits of autogenous block graphs are they are not expensive. No additional investment is required. No membrane is required. So the only thing is the patient and the implant. The cortical plate of the recipient site is penetrated with small burr at various points so that the blood supply is increased, the marrow space is open. Blocks from mandibular body exhibit slower revascularization than from the IA crest, but these are still preferred because you'll need a OT setting for that. Over the years, creeping substitution helps to substitute the block graft with the new. Now, autogenous particulate grafts. Particulate grafts have more osteogenic properties because the surface area is increased, but they cannot be used alone because they will resorb. They can be derived by milling the graft in a bone mill, or you could just use a bone scraper to just use that harvested graft and just scrape it off. You get a lot of bone, lot of autogenous bone, so much bone that you can just fill the space between the native bone and the bone block. You will always fill it with, because the surface area increases, the amount of bone automatically increases. You can just fill it with, and then still you'll have a lot of bone left. This is a bone scraper, safe scraper. Allograft, bone derived from a donor and used in another recipient of the same species. Allografts are stored in bone banks, like the Tata in India, are stored in bone banks in the form of fresh frozen allograft, FBBA or DFBBA. DFBBA is demineralized freeze real. The FBBA and DFBBA are considered more biocompatible and osteoconductive, but they are to be used in conjugation, another space maintainer material. Xenografts. Bone mineral derived from animal or bone-like minerals derived from calcifying corals or algae, from which the organic material has been removed to prevent immunogenicity. Deproteinized bovine bone minerals (DBBM) are both biocompatible and both osteoconductive also. DBBM could be produced by either high temperature treatment or chemical. Both the procedures result in DBBM of different quality. Xenografts are close to non-resorbable. They have been found to exist in bone biopsies even after 10 years of grafting. So that is the thing. When you use a xenograft, it never fully converts into native bone. It is never substituted fully. So that is a drawback. Alloplast, completely synthetic. No risk of disease transmission is the best thing. Benefits are the size of particles as well as the chemical composition can be varied and can be controlled by the manufacturer. So the three groups, calcium phosphates, bioactive classes, and polymers, they exist. Hydroxyapatite and beta TCP are the most commonly used grafts and the cheapest also. Hydroxyapatite is osteoconductive and non-resorbable, while beta TCP is also osteoconductive, but it is rapidly resorbable. So they are used in combination. Bioglasses are silica-based materials that were introduced in the early 1970s. See, in the early healing phase, more new bone formation is observed in defects which are grafted with beta TCP with TCP than with beta TCP, which resulted in more new bone formation than HA. Here also, more new formation is seen in defects with beta TCP. Implant placement with simultaneous GBR. Three more major points must be understood: that the implant must be placed in a correct three-dimensional position from both a functional and an aesthetic point of view. Must be possible to achieve primary implant stability in this specific position. The peri-implant bone defect must have a favorable defect morphology to allow predictable bone regeneration of the defect. The healing potential for new bone formation in an implant site with a peri-implant bone defect depends on general and local factors. The most important local factor is the ratio between the surface area of exposed bone and the defect volume to be regenerated. Just like in periodontal regeneration, my periodontist friend will understand. I mean, they know well that the more the walls available in a bone defect, the better the chances of healing. Suppose, for example, a three-wall defect, which has a three walls surrounding the three walls will heal is having a better defect morphology, will heal well because it has perfusion from three sides. Then a two wall, which has two walls, and one wall is the most difficult to build. If the alveolar crest measures less than 5 mm, you should always go for a staged approach. Two-wall defect has a favorable morphology, frequently found in post-extraction sites having a crater-like defect. The exposed implant surface is located inside the alveolar crest and hence has excellent regeneration potential. In contrast, in one wall defects, you need a block bone graft and GBR for horizontal bone augmentation, and then the implant is placed in the second stage. So, a CBCT is must to understand the bone walls, and then you proceed accordingly. If the exposed surface is a cortical one, multiple provision that is always done. If only autograft is used, the flap size has to be smaller because lesser the autograft integrates well. But when you use a layered graft like a autograft along with a layering of BBBM, a wider dimension of flap is flat. Bone fillers and membrane. We usually use a porcine derived collagen membrane and is considered the best for a GBR procedure. The EPTFE membranes, as we already discussed, they are rarely used except for vertical augmentations. Titanium reinforced membranes also are used. To accelerate new bone formation, the filler needs to have osteogenic properties, whereas a filler with low substitution rate is needed to maintain the created bone volume over time. So you place an autograft first, and then you place a filler with a low substitution rate to maintain the bone volume. That is DBVM line. Kusa et al. Suggested synergistically combining two graft materials. So this is his concept. Autogenous bone chips harvested from the same site are placed in direct contact with the implant. Low substitution filler like DBBM is applied on top of autograft. For patients who don't want to use a bovine material or something like that, you can also use a calcium phosphate. Graft is placed and then membrane is placed and then switch out. A flap design, very important, and wound closure also. The proper sterilization drilling protocol of 15 to 2000 RPM is must, and use of chilled saline is recommended. Prior rinse of chlorhexidine 0.2%, antibiotic prophylaxis, and midazolam to calm the patient is given 7.5 milligram orally. The flap could be a trapezoidal or triangular flap, that is up to your decision. And the mobilization of the full thickness flap through incision on the buccal or palatal aspect helps to achieve a tension-free closure. The partial thickness flap. These are some of the flap designs for the maxillary central incisor. You could use papilla sparing incision. You could use a wide incision. For if you go for the distal aspect of the canine, then the scarring will not be visible. The treatment implant placement in post extraction site. The treatment options. The first is immediate implant placement. Second is early implant placement, following some of soft tissue healing, that is after 4 to 8 weeks. Then type 3 is after 12 to 16 weeks, early implant placement following partial bone healing. The second is sorry partial with soft tissue healing. The third is with partial bone healing, and after the type 4 is 6 months following complete bone healing. A big periapical defect or something like that occurs is present, so we decide to do a late implant placement. A bone resorption process is a physiologic healing process to the in response to interruption of blood supply to the bundle bone lining the extraction socket from the periodontal ligament of the extracted tooth. Correct 3D positioning, good primary stability are requisite. Whenever possible, implant placement is combined with a simultaneous DBR procedure to avoid a staged approach, which is preferred by the clinician also and also the patient, because nobody wants to do two flap procedures. Immediate implants are always associated with increased risk of aesthetic complications, in particular gingival recession on the buccal aspect. This risk is more enhanced in patients with thin tissue biotypes. The dense cortical bone of the parietal wall can often cause the implant to deflect towards the facial aspect. An additional problem is also the relative lack of soft tissue to achieve submerged or semi-submerged healing. The facial flap has to be well mobilized and coronally advanced, often changing the position of the mucogingival junction in relation to the adjacent. So these are some of the problems faced during immediate implants, especially in the anterior region. The here connective tissue graft is placed simultaneously along with the implant placement and to achieve a good apposition of the, because we cannot always bring the flaps to close approximation, so we use the CPG here and then place the healing abutment. Early implant placement type 2 is preferred in aesthetic cases because when the socket is allowed to heal, it helps in gaining some keratinized tissue as well. But it is not recommended when there is no primary stability. Early implant placement type 3 is recommended in cases of periapical infection, where the bone is allowed to heal for 12 to 16 weeks. And the last type 4, late implant placement, following complete bone healing, for at least 6 months of healing is required. The only disadvantage is the collapse of facial width anatomy. It will definitely occur. Coming to autologous bone grafts again, these are the gold standard in implant grafts, in the bone grafts. They can be used for both horizontal and vertical bone augmentation to a significant level. Schmidt et al. Presented an animal study on vertical ridge augmentation in which implants were placed in rabbit skulls. Jovanovic et al. Achieved supracrestal bone regeneration in 5 dogs with submerged membrane technique. In 1994, Simeon et al. Reported the first human and histologic study of vertical bone regeneration of the trophic edentulous ridge with GBR techniques. The vertical or horizontal bone regeneration could also be achieved by EPTFE membranes and titanium reinforced EPTFE membranes. The adjacent tooth, for vertical bone regeneration, we must always understand that the adjacent tooth must have a bone peak, which will be the threshold of vertical bone gain. You have to understand that there is a bone peak, and that is the level of bone that you can predictably or you should aim to regenerate. The implants are then placed along with tenting screws, making sure not to, those are also made sure not to exceed the height of the bone peak of the adjacent teeth. Fixation screws are also used to secure the membrane lingually by mesial and distal screws. Okay. And a composite graft consisting of a 1:1 ratio of autogenous bone harvested from the mandible retromolar region and DBBN review. This is the technique by Dr. Isman Urban. These are some of my cases. You don't have the bone graft pick here. This is a temporary just placed that we got in place just before, say, 1 month before lockdown. This patient will be attending after the lockdown, and we are modeling this temporary for the context. We are constantly changing to make it ovate. PTR drilling through the rods. This is another protocol. This is for correct 3D angulation of the implant. We just go through the roots. This reference stopper here. placed an implant after healing, and this is final implant. These are the references. Thank you so much.
Thank you so much, Dr. Singh. Great presentation. Um, we have some questions for you
Thank you.
regarding, excuse my dog here. uh, we have some questions for you here, a couple of questions. One was about the osteo densification. The question is that that does not remove any bone.
Okay. Yes, osteodensification burrs do not remove any bone.
Okay,
When run in a counterclockwise direction, they preserve bone, which is very crucial in cases.
got it, got it, got it. You have to excuse my. So next question was regarding. I'm sorry about my dog's going crazy over there. Regarding uh, so what do you use in your practice? The question is that you use mostly allograft.
I yes, I use allograft, and I usually use a mixture of this allograft and autograft.
I see. Okay. So so you mix patient's bone with the allograft, basically. Okay. All right. Well, I'm just looking for more questions here. Okay. Uh, Next question here uh, is about the socket shield technique. Um, is that something that yeah, you use regularly in your practice?
Yes, not regularly. I mean, since I've learned some of it, I'm using. I initially failed badly in this socket shields, but it is a learning curve that is associated with socket shields. And why we need a socket shield? Because it's the best procedure that could happen to implant dentistry. I mean, when you remove the tooth, you remove the bundle bone that is a part of the tooth, and we must always understand that the bundle bone on the facial aspect is approximately 2 mm. So if we remove the tooth, the bundle bone or the it goes away, and you will definitely, even if you graft, even if you do a socket preservation, it will definitely resolve. The bundle bone is gone, so the contour that you already had before the tooth extraction will be gone in approximately 3 to 6 months. It will be gone. So the best thing is to preserve the buccal part of the bone, be as close to the nature as possible, and then place the implant in the palatal wall of the socket. That is the best thing. If you cannot, if there's a pathology in the epiperiapical region, you could always go for a staged approach. If you cannot achieve primary implant stability, that is a foremost important in a socket shield. You need to have a primary implant stability. If you don't have a primary implant stability, you could always go for a Glocker's technique, wherein you could, prepare the shield, curate the periapical the pathology, and then mix an autograft and a beta TCP or whatever you feel like, and then go for a staged approach. That is the best thing you could do.
Got it. Got it. Well, thank you so much, Dr. Singh. I appreciate you taking time and sharing your knowledge with us here on Global Interdisciplinary Summit 2020. Do you have
Thank you
anything
so
else?
much.
Uh-huh.
Thank you, sir. Thank you so much. I must thank Dr. Arun Garg for giving me an opportunity to share my knowledge. And I also would like to thank my mentor, Dr. Puneet Ahuja from New Delhi. He's been very helpful in guiding me along with this. And I wish you guys all the best. You guys are doing a great job. Thank you so much.
Thank you. Thank you. Thank you
Greetings
for
from
coming
India.
on.
Thank
I
you.
appreciate it very much. Thank you.
Thank you, sir.
Thank you.